This lecture is going to look at the portal venous system. The portal venous system is really important, and there's a few of them throughout the body. But a portal system in general is where a capillary bed runs into another capillary bed before it returns to the systemic circulation and passes through the heart. So, for example, we're used to blood passing via the arteries to a capillary bed, say a muscle, and then into the venules and the veins, which take it back to the heart. It can then be sent to the lungs for gases exchange to occur and then return and be distributed again. But this portal system allows blood that's passed through a capillary bed to then pass to another capillary bed before returning to the heart. And the portal venous system is a real good example of this. Venous drainage from the GI tract and the accessory organs travels to the liver, the second capillary bed, via the hepatic portal vein. And then via hepatic veins does it then drain into the systemic system and towards the heart. We also have some anastomoses between the portal system and the systemic system, and this occurs normally during pathological situations, which mean blood can't pass through the liver and it's actually directed via small blood vessels into systemic circulation. So the portal venous system receives poorly oxygenated blood. It's nutrient-rich blood because it's passed through the GI tract, but the oxygen's been used up by those tissues to actually absorb the nutrients. And blood from the gastrointestinal tract within the abdomen and the pancreas and gallbladder and spleen passes to the liver. It's carried to the capillary beds of the liver, and then subsequently it's returned to the systemic circulation. So let's have a look. For the arterial supply, we did foregut, midgut and hindgut, and we can keep these similar principles. So here we can just concentrate with organs such as the stomach and the liver. So if we look at the organs within the foregut, remember we have the esophagus, the stomach, spleen, pancreas, duodenum, and we have the gallbladder. And we can see that we have a whole series, look at the stomach here, we can have a whole series of veins draining this region, and they drain into one of several blood vessels, but ultimately they end up going to the hepatic portal vein. So for example, the esophagus may well drain into the left gastric vein, which then passes into the hepatic portal vein here. We can see the stomach with its left and right gastric veins draining directly perhaps into the hepatic portal vein. The left gastromental may well drain into the splenic vein, which then passes back to the hepatic portal vein. The right gastromental vein, that may well pass the superior mesenteric vein, which we can see running around in this direction, but then ultimately passing into the hepatic portal vein. So there is considerable variation, and this detail on the side of the screen is really just an indication of the most likely route. But ultimately, this blood passes back to the hepatic portal vein. We can see some other examples for the gallbladder. It would be the cystic vein, which drains directly into the hepatic portal vein. Similar occurs for the midgut and the hindgut. If you're familiar with the arterial supply, then the venous drainage will be that much similar, very similar to it. So the ileum and the jejunum will drain via ileal and jejunal veins. These will drain into the superior mesenteric vein, so they'll drain into the superior mesenteric vein here. The cecum and appendix, ileocolic vein, and that can drain into the superior mesenteric, alongside the right colic and the middle colic veins, all draining into the superior mesenteric vein. Here we have a slight discrepancy, a slight alteration from the normal plan you would suggest, and that is where the superior rectal veins here and the sigmoid veins descending parts of the colon draining via the left colic vein. These actually pass into the inferior mesenteric vein. Now, the inferior mesenteric vein actually runs up towards the splenic vein in a significant number of people. The inferior mesenteric vein runs up into the splenic vein. And the splenic vein then, as we've suggested before, unites with the superior mesenteric vein. And here we have the formation of the hepatic portal vein. And if you remember, this occurs posterior to the neck of the pancreas. We can see a number of ways in which this can occur in this general schematic here. And all the time we have the hepatic portal vein. So we have the hepatic portal vein here. We have the hepatic portal vein here. And we have the hepatic portal vein in these two examples as well. And what I'm doing is I'm just trying to illustrate the variation that we have. So we can see this one here, this one here, this one, and this one. This is our left gastric vein. Now, the left gastric vein can take any one of these courses. The left gastric can drain directly into the hepatic portal vein here, or the left gastric vein can drain into the splenic vein, which we have here. So we can see we have some possibilities for the left gastric vein draining into the hepatic portal vein. Similar happens here. Or it can drain directly into the splenic, which we have here. We can see that the inferior mesenteric vein, here we've got the splenic again, the inferior mesenteric vein can drain directly into the splenic. So here we can have the inferior mesenteric vein taking hindgut blood directly into the splenic vein, and then as it unites with the superior mesenteric vein, we have the formation of the hepatic portal vein. This one down here is very similar. It's just showing the alteration with the left gastric in place here. On this side, we can see that the inferior mesenteric vein can actually drain into the superior mesenteric vein here instead. So it can drain instead of into the splenic, it can pass into the superior mesenteric vein. And then this will form the hepatic portal vein with the splenic. So we can see that we have multiple combinations where the left gastric drains into the hepatic portal or into the splenic, or where the inferior mesenteric drains into the splenic or into the superior mesenteric. There's multiple combinations which we can have. I don't think it's necessarily important to be rigid of which one or to be confused about them, just to appreciate that there's considerable variation. So the portal systemic anastomoses, these are connections between the venous portal system and the systemic circulation. And typically, these are very narrow, quiescent connections that do not typically conduct a significant volume of blood. So they're usually quite quiescent. They're usually not very active. However, when the portal circulation is compromised, maybe liver disease, cirrhosis, or pressure from a neighbouring tumour, blood can't flow through the liver adequately because it's blocked. But the pressure forces that blood to return to the heart via these alternative routes. And there's a number of them. So if we have cirrhosis or liver disease and the architecture of the liver is preventing the hepatic portal vein taking blood through, then it seeks out these alternative routes, these portal systemic anastomoses. And we have four of them. We have them between the esophagus and the stomach, esophageal and gastric veins. We have them occurring between the rectal veins, between the systemic and portal parts of those rectal veins. We have paraumbilical and we have epigastric veins. And we have colic and retroperitoneal veins. And we'll explore these in the next few slides. So with portal hypertension, more than expected blood passes through these portal systemic anastomoses, leading to these veins becoming dilated and what we know as varices. So let's have a look. These portal systemic anastomoses. Here on the screen, we can see the normal portal system in this purple color and the systemic circulation in this blue. And we can see that if blood can't pass through in this direction, typically it go into the portal vein and then into the liver in this direction. If this is blocked, if this is prevented, then blood can actually pass up via these esophageal veins into your azygous system, and that will take it back to the heart that way. Now, what we can see if we look into the internal aspect of the esophagus, we see a normal, nice, flat architecture to the inside wall of the stomach. But if we look with these esophageal varices, where these usually quiescent blood vessels are now swollen, we can see that they're actually causing these bulges into the wall of the esophagus. These can potentially rupture and leak blood into the esophagus, and you may cough up, vomit blood. So that's one of them, the esophageal and gastric anastomoses. The connections between these gastric and esophageal veins connect to the azygous system in the thorax. And like I said, if these were to rupture, you can get some quite severe bleeding. If we now look at a second portosystemic anastomosis, we can see these are occurring at the rectum by these rectal veins. We can see that typically the superior rectal vein is draining blood up in this direction, but we can also see that if blood is prevented from passing through the liver, then it can actually drain into the internal iliac vein via some other rectal veins, via your inferior or middle rectal veins perhaps, and these can pass back into the internal iliac vein. These can pass back in this direction. Now, because again, these blood vessels aren't used to receiving this proportion of blood, then we can have what are known as hemorrhoids. We can have bulging of these blood vessels into the wall of the anal and the rectal canal. And we can see some internal ones here, and we can see some external hemorrhoids here. So that's the second portosystemic anastomosis. We can also have what are known as para-umbilical or colic anastomoses, and these para-umbilical ones actually reopen some of the blood vessels which are on the anterior abdominal wall and that pass around the round ligament of the falciform ligament that join the superficial epigastric veins on the anterior surface of the abdomen. So we can see if blood is prevented from passing to the liver here, that it can actually pass towards some of these umbilical veins, these para-umbilical veins, and they can end up dilating these. And these are around the umbilicus, as ultimately they go to return into the iliac system. If we look at these, then we can see that as they swell, they actually take the appearance of caput medusa, the kind of snakes of hair that from Greek mythology that is radiating underneath the surface of the skin as the increased pressure in these blood vessels now pushes onto the skin. We can also see some small colic branches, and these unite with what are known as retroperitoneal veins, and they can also drain into the inferior vena cava. So we have the potential for a whole series of portosystemic anastomoses that allow blood to pass back from the liver if it can't penetrate through the liver because the architecture has been ruptured, has been damaged, is not able to transmit this volume of blood. Then via these portal systemic anastomoses, blood can find a different route. So we've looked at the principles behind a portal system and then the patterns of venous drainage from the foregut, midgut and hindgut, and the variations in the formation of the hepatic portal vein. And then we've looked at a whole series of portal systemic anastomoses.